Good morning, everybody. I hope everybody's having a good week. I know everyone is probably looking forward to spring break that's coming up next week. Uh, Today, we're going to talk about pediatric fluid and electrolytes. Uh, Fluid and electrolytes are important for your pediatrics for the maintenance water requirement. You need to be very conscious of this as a nurse. The maintenance water requirement is the amount that's needed to replace a obligatory fluid loss. This fluid loss can be either insensible, evaporative, or losses through urine and stool. Your insensible losses are losses through respiration in their skin, such as sweat. The amount and type of losses can be altered by disease states like fever, diarrhea, gastric suctioning, and pooling in body spaces. Fluid requirements are based on their body's requirement in a normal metabolic state at rest. They are then increased or decreased based on the water loss. Okay? So let's talk about some of the increased fluid requirements. Okay, these are just examples here, such as fever. Now, when they have a fever, if the fever is over 99 degrees, it increases their insensible losses by 7 milliliters per kilogram for 24 hours. Okay, that's for each degree above 99. Children also have increased surface area relative to their fluid volume, and these play a factor that contribute to increased fluid losses in your young ones. Okay, of course, the vomiting, the diarrhea, burns, all of those also play into effect with the younger patients. You also, like I said before, the body surface area, which is greater in a child. It allows for larger quantities of fluids to be lost in insensible perspiration through the skin. Also, their basal metabolic rate. Any condition that increases the metabolism causes a greater heat production. It also causes insensible water losses and an increased need for water for excretion. Okay. Also, the kidney functions. The kidneys are functionally immature in children. Okay. Of particular importance in the fluid balance is the inability to concentrate or to dilute the urine. They have trouble conserving or excreting sodium, and they also have trouble modifying the acidity of their urine. Okay, they are more likely to become dehydrated when they're given concentrated formula, or overhydrated when they are given excessive water or formula that is too dilute. I have listed here on this slide your reasons for increased fluid requirements. The fluid requirements are going to depend on the hydration status, size, environmental factors, and underlying diseases that the children are going through. Okay? Decreased fluid requirements. I've got a list of the reasons here. You can see CHF, syndrome of inappropriate antidiuretic hormones, your mechanical ventilations, also your increased intracranial pressure. Fluid requirements are estimated from a child's age, their body weight, and their degree of activity and body temperature. Okay, total body water percentages vary among individuals due to the amount of body fat they have, just like with adults. Any condition that increases their metabolism causes that greater heat production. Remember, like I said, insensible losses, and increased need for water excretion. Okay? Particularly important is that, like I said before, the immature kidney function, the inability to concentrate or dilute that urine, fluid requirements are going to depend on hydration status, the size, the environmental factors, and the underlying diseases that are going on with your patients, like I've said before. Okay? Now, here I have given you the chart that's in your book on daily fluid maintenance requirements. It is a must that you know this for the test, as well as for caring for a child in the hospital. When you get to the hospital, you will have some nurses that are caring for pediatrics, and pediatrics are not their specialty, just like Miss Smedley. They're not my specialty. But I do know and am aware that their body fluid maintenance requirements are quite a bit different than in adults, okay? So let's see if you can figure one of these out. Excuse me. What would the fluid requirement for a patient who weighs 16 pounds be? Okay? So as you can see from your formula here that you're going to have to take this from pounds to kilograms. So let's do that first, all right? You're going to have, what? Their weight's going to be, what, 35.2 kilograms? Okay? So let's use the formula we have here. We got 35.2, and as you can see on this, it would be the bottom one is greater than 20, and these are where it says body weight, these are kilograms, okay? All right, so it's greater than 20, so we've got 1,500 to start off with for the first 20 pounds. And our patient weighs 35.2 kilograms, right? So that leaves us with an excess of 15.2 kilograms. So we're going to multiply that by 20 milligrams per kilogram, right? So we're going to multiply it by 20, and that's going to give us 304 for that 15.2, right? So we're going to add that 304 to your 1,500, and that's going to give you 1,804 milliliters of fluid. That's going to be a maintenance requirement for a child that weighs 16 pounds. Like I said, your book has got this chart in it, and make sure, and Miss Candler has gone over this with you when we did the IV fluid calculations. So you should be well versed in this, but you need to make sure that you're well versed in it. When you get onto the pediatric floor in the hospital, your instructors will be asking you if the fluid that is ordered for the patient is appropriate for the patient's size, okay? Now let's talk about some signs and symptoms to assess for water intoxication. You're going to see irritability in the children, moist rails in the lungs, increased spinal fluid pressure, and I have the whole list here. I'm not going to sit here and read it to you. It also gives you the labs. They're going to have a low specific gravity, okay? They're going to have low serum electrolytes, have a low hematocrit, and their urine is going to depend on their fluid volume, okay? If they're hypovolemic, their urine volume is going to be decreased. If they are hypervolemic, you might see an increased urine output. Water intoxication does not happen as often as dehydration does. Children can ingest excessive amounts of electrolyte-free water and develop a concurrent decrease in their sodium. When they do this, you're going to see accompanying central nervous system symptoms on these patients. It can be caused by acute intravenous fluid replacement, where they're getting fluid too rapidly, or it might be that they're having dialysis too rapidly. It can be from them having tap water enemas, feeding an incorrect mixture of formula with either having excessive water in it, okay? Or they can have you can see this with too rapid of a reduction in their glucose level, such as in your patients with diabetic ketoacidosis. Excuse me. All right, administration of inappropriate hypotonic solutions like your 0.45% normal saline can cause a rapid reduction in their sodium level and produce the water excess. Okay, you're going to look for a decrease in their glomerular filtration rate, and the ADH levels are going to be inappropriately reduced, and this can lead to water intoxication because their kidneys are unable to excrete the water excess effectively that the patient is experiencing. It can also be seen in infants who receive overly vigorous hydration during a febrile sickness. These are your patients where they're sick and mama keeps putting water to them and putting more water to them, okay, to help them because she is trying to help cool them off. Excuse me. Now let's talk about our management for water intoxication. You want to limit the fluid intake. You want to administer diuretics such as your Lasix and your thiazides to these patients. You're going to monitor their vital signs, monitor that for neurological signs and symptoms such as their confusion, lethargy, those types of things. Determine and treat the cause of the water excess. So if it's, for example, from the patient getting tap water enemas, you're going to want to stop the enemas, increase their fluid intake with electrolytes, okay? Analyze laboratory electrolyte measurements, and implement seizure precautions on these patients, because if their sodium gets low enough, it will trigger seizure activity in these patients. Okay, now what you would see with management on water intoxication, if these patients are responding well to your therapy that you're doing, you should see the electrolyte levels increased with effective management of their problem. Okay, so next we've got some signs and symptoms of dehydration to assess for, and it's a pretty lengthy list, as you can see. The labs, you're going to see an increase in their crit. Their lights are going to be variable. In other words, their electrolytes, it's going to depend. Some will be high, some will be low. It depends on what one you're looking at. They'll have a low bicarb level. Their urine can be variable. Like I said before, it's going to depend on if it's isotonic, if it's hypotonic, or if it's hypertonic dehydration that they're experiencing. They can have an increased bun and high osmolarity. Okay? Depends somewhat on the proportion of electrolytes lost with water. Their dehydration is a common disturbance in infants and children, regardless of the cause. It can result from impaired oral intake. It's often the result of abnormal losses like your vomiting and your diarrhea. When oral intake only, especially when their oral intake only partially compensates for their abnormal losses. It can include conditions like diabetic ketoacidosis and burns as well. Dehydration can be classified in 3 categories on the basis of osmolality, and depends primarily on the serum sodium concentration that is in the body fluid. Okay, can be either isotonic, hypotonic, or hypertonic. Isotonic is the most common in children where fluids and electrolytes loss is balanced. Okay, isotonic you'll see a reduce in the plasma volume and the circulating blood volume, which affects the skin, the muscles, and the kidneys. Okay, your plasma sodium remains within normal limits of 130 to 150 milliequivalents per liter. Hypotonic occurs when the electrolyte deficit exceeds the fluid or the water deficit. Okay, The water moves from the extracellular to the intracellular. Your physical signs are going to be more severe with smaller fluid losses than in the other two types with the hypotonic. Okay, your sodium concentration is going to be less than 130. In hypertonic, you'll see the water loss exceeds the electrolyte loss. This is the most dangerous type and requires more specific fluid therapy for your patients. They experience fluid shifts from the intercellular to the extracellular fluid compartments. Okay? Their plasma sodium concentration is greater than 150. It consists of a greater degree of water loss for these patients. Shock is going to be less apparent, but they do have central nervous system disruptions, including altered levels of consciousness. They'll have poor ability to focus their attention. Excuse me. You'll see lethargy, increased muscle tone, or hyperreflexia in these patients, and they'll have hyperirritability to stimuli. These are going to be your little patients that you're going to go in and you're going to see that when Mama and Daddy wakes them up, they start hitting and slapping at Mama and Daddy for no reason at all because they are easily irritable. Okay? These central nervous system changes are very serious and they can result in permanent damage if they're not corrected. Okay? Now let's talk about management of dehydration. All right? Compensatory mechanisms for dehydration are vasoconstriction of the peripheral arterioles. That helps to maintain the pumping pressure of the heart. Okay. Renal compensation is going to be seen with secretion of ADH to conserve the fluids and initiate the renin-angiotensin mechanism, and aldosterone release is going to help promote the sodium retention and the water conservation. If vasoconstriction can't be kept up, the blood pressure is going to fall, resulting in tissue hypoxia and accumulation of lactic acid, pyruvate, and other acid metabolites that are going to contribute to these patients running the risk of metabolic acidosis if it's not corrected. Now, on your pediatrics, you need to realize that a low blood pressure is usually a very late sign of shock, and it can be heralded in by the onset of cardiovascular collapse in children. Okay? Correcting the fluid loss or deficit and treating the underlying cause is the main medical management for these children. The degree of dehydration varies from mild, which is less than 3% in an older child or 5% in infants, to moderate, which is 5 to 10 in infants and 3 to 6 in older children, and severe, which is 10% in infants and more than 6% in your older child. Okay? Losses of 50 milliliters per kilogram is considered mild, but a loss of 100 milliliters per kilogram produces severe dehydration, so you can see that there's a very small range in between the two. Weight is the most important determinant of the percentage of total body fluid lost in infants and young children. You must weigh them and weigh them accurately. Okay? Other predictors can include their change in level of consciousness, like I said, from irritability to lethargy. Okay, altered response to stimuli from having decreased skin elasticity and turgor, also having prolonged capillary refill, and with children it would be longer than 2 seconds, because a normal capillary refill on a child is about 2 seconds, okay, instead of the 3. You can see increased heart rate on these patients, and they'll have sunken eyes and fontanelles, okay, especially in the young baby to infant stage, okay, before those fontanelles close. Okay, the earliest detectable sign of dehydration in a child is going to be tachycardia. This is going to be followed by dry skin and mucous membranes. Like I said, the sunken fontanelles, signs of circulatory failure, like they'll have coolness and mottling to their extremities. They're going to have a loss of skin elasticity and prolonged capillary refilling time. Like I said before, capillary refill time normally less than 2 seconds. With these, you can see greater than 3 seconds, okay? For mild replacements, you're going to give fluid over a 4 to 6 hour period of about 50 milliliters per kilogram on the child, okay? For moderate dehydration, you're going to give about 100 milliliters per kilogram. With a child that has diarrhea, they might have to be given 10 milligrams per kilogram for each stool that they get in order for you to replace their fluids, okay? If the child's not thirsty or if it's refusing to drink due to vomiting, rehydration can be reached by giving them about 2 to 5 milliliters in a syringe or a small medicine cup every 2 to 3 minutes. Usually they can tolerate that pretty well, and then work your way up into larger amounts as they can tolerate, okay? They might have to be given Zofran, especially for those with acute gastritis or vomiting, to help increase their oral intake. Plus, they will need an increased time span for their oral rehydration therapy, okay? Older children may take small popsicles instead of fluids that require them to drink when they're nauseous, okay? Let's see here. IVs may be required if they can't meet their fluid and electrolyte needs to replace previous deficits, and they have abnormal or ongoing abnormal losses, so you might have to hook them up to an IV. Usually these patients will have severe dehydration. They're going to have uncontrolled vomiting. They're not going to be able to drink for some reason, and those with severe gastric distension are going to be the ones that you give IV therapy to, okay? So you're going to provide that replacement. You're going to provide maintenance fluids and electrolytes, right? You want to determine the cause of the fluid water deficit and correct that. You're going to measure their INOs, and you need to be meticulous on that. You're going to monitor those vital signs to make sure that they're not tachycardic and that you don't see any changes, correct? Any decreases in blood pressure. You're going to monitor their urine-specific gravity, because that will help determine if they have a fluid shift or if they have a true dehydration, okay? Monitor their body weight, and you're going to monitor their serum electrolytes, right? Now let's talk about nursing management, okay? You're going to perform thorough assessment on these children to begin with, and then you need to frequently reassess them. Check those vital signs. Check the skin, check the mucous membranes, weigh the patient, check the fontanelles on the infants, okay? Look for some sensory alterations. Like I said, accurately measuring INOs, and make sure that you include all urine, stools, vomitus, and sweating with that, okay? Now, how do you figure an output from a child that's wearing a diaper? 1 gram of wet diaper will equal to 1 milliliter of urine. Okay? And your book, in your pediatric book, it gives you exactly how to figure, let me back up here a minute. In your pediatric book, it gives you the exact amount of urine that you should expect to see outputted from the different categories of children. And I was trying to look right fast and see what page that's on. I'm not really sure. And I don't see it right off the top of it. So, but it should be in there around 768, 769, somewhere in there. Okay. But within 24 hours of birth, they should have their first voiding. You'll have 2 to 3 voids in the second 24 hours of life. They should have 3 to 5 in the third and fourth days of life. They should have a minimum of 5 to 6 in 5 to 6 days of life, and 6 to 8 voids per day for infants older than 5 or 6 days. For infants younger than 1 year, they might be voiding every 1 to 2 hours, and toddlers will usually void approximately every 3 hours. Okay. Now, your book has a great chart in it, and I have actually just literally put the chart down for you on these PowerPoints in case you wanted to study it from the PowerPoints and not have to wag your book around. But it starts on page 765, and you need to know this chart, okay? Hyponatremia and the causes of it I have them listed here, like prolonged low sodium diets, fever, anything, think of it, anything that decreases the sodium intake or increases the water output can cause hyponatremia in your patients. For children, nausea, vomiting, diarrhea, gastric suctioning, wounds and burns, also those fevers, you know. You can also see patients that have like cystic fibrosis, renal disease, DKA, and those that are malnourished will have a higher incidence of having hyponatremia. Now, the next slide shows you the causes. The next slide shows you the signs and symptoms of hyponatremia to assess for in your children. You're going to look for dehydration, so what are you going to do? Check that skin turgor. See if they're having trouble navigating. You know, check the dizziness. See if they're having trouble setting up, or if they tell you everything's spinning around. You know, check their stomach. Ask them and their parents if they're having abdominal cramps. You know, check their muscles for weakness. Have them squeeze your fingers. Make it a contest. See if they're strong. You know, nausea. It's normal for a child to be apprehensive when they're in the hospital surrounded by strange people. However, ask the mother about their apprehension level when no one else is in the room, okay? Because they can have apprehensive moments. With mild hyponatremia, you're going to see apathy, weakness, nausea, weak pulses. With moderate, you're going to see a decrease in blood pressure, and you're also going to see lethargy. Now, of course, the labs are going to show you that their sodium level is below 130, but it can be up in the normal range as well if they are losing volume as well as electrolytes, okay? So in other words, if they are losing a lot of water as well as electrolytes, that sodium level might be within normal range. Also, their urine-specific gravity is going to depend on water deficit or excess in these. So are they hypovolemic or hypervolemic? Now, that's going to depend, or that's going to change the effects on their specific gravity. For your management of hyponatremia, you're going to determine and treat the cause of the sodium deficit. So find out what's going on, find out if they're getting too much pure water without any vitamins and minerals or any minerals in it. Find out if they are getting inappropriate sodium concentration of IV fluid. You need to monitor that fluid and or intake and output, and make sure that the IV fluids that you're hanging on the child are appropriate. Okay? Now let's look at the causes of hypernatremia. You can see high sodium intake either externally or from IV. So maybe they're eating lots and lots of chips that are high in salt content, drinking lots of soda pops that are high in salt content, or maybe they have a high salt content IV fluid. Patients with renal disease, anything that slows down the excretion of fluids and excess sodium are going to cause the patient to be hypernatremic. Okay? Fever, where they're losing fluids but they're not losing sodium. Okay? Insufficient breast milk intake, the baby's not getting enough milk. Right? High insensible water losses, which include your increased temperature, your increased humidity outside, hyperventilation, diabetic insipidus, and hyperglycemia can cause hypernatremia. Okay, so what are we going to look for on these patients? They will have dry, sticky mucous membranes. Their temperature is probably going to increase. You'll see nausea, vomiting, ugliuria. They're going to have a progression in disorientation. They might have seizures. You can see muscle twitching, knuckle rigidity, lethargy at rest. They're going to be hyper irritable when they are aroused. They're going to have an intense thirst. Their skin's going to be flushed, and they might have a hoarseness to their voice. Okay? You're going to see labs where their sodium is above 150. They're going to have a high plasma volume and also be leaning towards alkalosis if they're not alkalotic. Okay? Management of hypernatremia. You're going to determine and treat the cause of this sodium excess and get rid of it. Okay? You're going to administer IV fluids to help what? Dilute it down. Okay? As prescribed. The doctor will prescribe those. Usually it's half normal saline or 0.225% normal saline. You're going to measure their intake and output very closely. You want to monitor that lab work closely. Monitor their neurologic status. Ensure that they have an adequate intake of breast milk. Now, you might have to provide some lactation assistance for mothers with babies. They should have received it before they went home from the hospital, but they might need a little bit of a refresher on this. And hey, remember guys, this is where you can always collaborate, correct? So get somebody up from OB that can help with this, with lactation and latching on, okay, and getting an appropriate amount. Okay, the management of hypernatremia. Like I said, you're going to determine the cause and treat the sodium excess, administer the IV fluids, and do all of that with the mother. Don't forget. Now, causes of hypokalemia. Let's move on to the potassium now. I know everybody loves this one. Starvation and malnutrition can be some of the causes. Diuresis in the healing stage of burns. So after the initial burn stage, then they have lower fluid volumes, lower electrolyte volumes, and you will see after that initial damage that they are hypokalemic. Okay? You will see patients with diabetic ketoacidosis, abnormal GI losses. IV insulin for DKA can cause this patient to end up being hypokalemic. Conditions with poor food intake, your IV fluids without having potassium. Diuretics and corticosteroids. Y'all please remember, corticosteroids can cause hypokalemia. Okay? Just like you need to monitor their blood glucose when they are on steroids. You also need to monitor their potassium level. Diuretic phase of the nephrotic syndrome, if they have potassium losing nephritis. Familial periodic paralysis can also lead to hypokalemia and alkalosis as well. Okay. Some of your signs and symptoms of hypokalemia to assess for are, you're going to watch for hypotension, ileus, irritability in these patients, tachycardia. They can even be bradycardic. It depends on how far they have gone along in their hypokalemia. Apathy and drowsiness, fatigue. You'll see muscle weakness and cramping and stiffness. Paralysis and hyporeflexia. So you're going to be seeing deep tendon reflexes that are not responding. With the cardiac, like I said, you have the tachycardia and the bradycardia, but you also will see arrhythmias and maybe a galloping rhythm, okay? On labs, you're going to see a serum potassium level that is less than 3.5, and you're going to find some abnormal EKG readings on these patients, and they do. Even hypo and hyperkalemia both need to be monitored with ECGs, okay? You're going to see a notched or a flat T-wave. T-wave. They're going to have a decrease in their ST interval. And these patients can even throw some PVCs, okay? So those are what you're going to be monitoring for. Now, management, what are we going to do for hypokalemia? You're going to determine and treat the cause of the potassium deficit. You need to monitor those vital signs, and like I said, monitor that ECG. Okay, you're going to administer potassium supplements. How these potassium supplements are given and at what strength they are given is going to depend on their renal function. Okay, if they're getting an IV replacement, you need to administer it very slowly, very small amounts. Available at a time to infuse in these patients. With the children, you're going to use the Solucet or the Buretol. Okay, so you only put an hour's worth of fluid in at a time. Okay, you want to always monitor that ECG, especially if they're giving an IV bolus of potassium replacement, if their hypokalemia is very severe. Okay, increase oral intakes, offer them fluids that are high in potassium and foods that are high in potassium. And your pediatric book doesn't have an extensive list on this, but your med-surg book does, so you need to go over there and make sure that you're familiar with the foods that are high and fluids that would be high in potassium for these patients, okay? You're going to also evaluate their acid-base status because like I said earlier, you're going to have to watch these people for alkalosis, okay? Now let's talk about the hyperkalemia. I've got listed here your causes. You can have renal disease or renal failure, burns, any type of crushing injury, severe dehydration, and when I say crushing injury, I mean a bone crush or a pelvic crush. Burns are the same way. When you have severe tissue damage to begin with, the tissue is damaged, the cells are broken. What is the biggest component in the cell? Right, it's potassium. So you have to watch for them to become hyperkalemic because of the release of potassium from cells that were damaged, okay? You also have hemolysis and dehydration. The use of potassium-sparing diuretics, patients that have Addison's disease, patients with metabolic acidosis, any rapid administration of IV potassium, and that should not happen, correct? Transfusion that the patient receives when the donor blood is old can also lead to hyperkalemia because those cells are dying off and releasing their potassium, okay? Or an increase in potassium intake, such as with, in your older adults, salt substitutes. You know, with the children, maybe they just go hog wild for cantaloupe, okay? Or some other type of food that's high in potassium. Okay, what are the signs and symptoms that you're going to be looking for? You're going to assess some muscle weakness, okay? Watch for flaccid paralysis, twitching, hyperreflexia in these patients. So when you go to test their deep tendon reflexes, you're going to see one that can literally kick you in the face, right? They will have bradycardia. You might see some VFib, and if it's not corrected, it can lead into cardiac arrest. They'll have oliguriria. You'll see apnea that can lead to respiratory arrest if it's not corrected. Your labs, you're going to see a serum potassium level that is higher than 5.5. Their urine output or their urine volume is going to be variable. It's going to depend on the overall volume of the patient if they're hypovolemic or hypervolemic. Okay, EKG findings you're going to see a flat P wave. They're going to have a really peaked T wave that have a widened QRS, and they're going to have an increased PR interval. Now these are widened or increased basically because of the transmission, right, of nerve impulses. Okay. So what are we going to do to manage this? We're going to determine and treat the cause of potassium excess. You want to monitor those vital signs. As before, you're also going to monitor the ECG. Okay? They might be administered exchange resins as prescribed by their doctors, such as K-exolate to bind with the potassium. Administer IV fluids as prescribed. They will be on IV fluids to help hemodilute the potassium down. Okay, if their level is too high, they will be given IV insulin to facilitate the movement of potassium back into the cells. Okay, this insulin will be given in a fluid that is high in dextrose. Okay, so you will also need to monitor these patients for hypoglycemia. Okay, when you're giving this, you're going to monitor that potassium level, and you need to evaluate the acid-base status to see if they're having improvement in their acidosis. Okay, that's the end of our pediatric. I hope that helped you some. As always, if you have questions, please feel free to contact me either by sending me something on Blackboard, or you can even text my cell phone. Y'all have my cell phone number, or see me in clinical sometime. I hope y'all have a great spring break, and I'll have another one dictated to you for the adults in just a little bit. Also, I have put up for you an article that goes along really well with this, which is on IV fluids and which ones are appropriate. You need to be familiar with it. Please read that article. It's a pretty short one, and it has some questions at the back that will help you study for your test. Okay, if you have any questions, just let me know. Thanks. Goodbye.